So I'd like to thank everybody who's now currently joining on for the meeting. We're about halfway through the attendees we're expecting, so we'll wait a couple more minutes and then we'll get the webinar underway. Okay, we're going to give it another 1 minute to let the last few stragglers join on, and then we will start the webinar. Okay, I'd like to thank everybody for joining us for the CAS's second town hall meeting. This is where we're going to start looking at how to manage the airway, and the title of this webinar is Doing Things Safely, Airway Management and COVID-19 Disease. I'd like to start first by introducing the today's speakers. I'll introduce myself. I'm Daniel Bainbridge, and I'm the president of the CAS, and I will actually be moderating today's webinar. And in the interest of time, I'm simply just going to present the list of the speakers and their affiliations, just so that everybody knows where our speakers are from and what their interests are. To again, let everybody know where we're at in terms of in Canada. And again, just remind you, we're going to take questions via the webinar. I will go through each of the questions and try and pool them so I can ask the speakers. We will try in this webinar to save the questions until the end of the talk, just to try and allow the webinar to flow as well as we can. This is where we are at in Canada right now, and therefore it's obviously very pertinent to what we're doing. I'm going to start off with getting Dr. Duggan to start first.
Thank you everyone for joining us. We're up to 879 participants right now. Last week we dealt with the use of personal protective equipment, and this week, even though these two things overlap, we're going to be mainly dealing with airway management. I'm sure everybody on this call is getting still nervous and yet saturated with information about how to manage COVID-19, particularly PPE and airway management. We on the panel wanted to just take a moment and acknowledge all of your efforts and concentration gearing up for this to come to Canada over the next week or so, and some of it in Toronto and Vancouver already starting. For this webinar, I want you to just slow down a bit, take a sip of water, and we're just going to mainly focus on back to basics, general principles of airway management, however, with particular priorities regarding COVID-19. So big square wave breath, everyone, and let's get going. And we can go to the next slide, I think, here. Back a sec. Forward. Oh,
Sorry, maybe just mention.
sorry, Dan?
Sorry, that slide got dropped, so maybe just talk about it.
Oh, sure. So one of the things that I want to focus on with everyone is the fact that we are not actually going to be prescribing certain maneuvers or things to do. We are going to be sticking with the principles with, of course, they need to be coordinated with your local resources, your local infection control, and the resources that you have in ICU, emergency medicine, and anesthesia, as well as family medicine and primary care. So I think we will go to the next slide. We are so honored to have Tim Cook joining us from the UK today. Not only is he, I would call him a dear friend and colleague, but he is probably the most insightful and a practical clinician with respect to airway management research and teaching that we have in the world at present. I invited him to give a lay of the land worldwide and the issues that he's now facing in the UK that we will be facing very soon in Canada. Tim, over to you.
Laura, that's very kind of you. I think probably misjudged, but very kind. I'd like to thank the Canadian Society for inviting me. Just check you've got my screen. That's something's hiding me from doing that. So that should be my screen now coming up and switching. Yeah, so I'm going to start by saying hello to the kind people who looked after me when I was in Worcester last year at the meeting there, and hello to Sonia Payne in London, Ontario. And I do this absolutely intentionally. This is an awful time, the pandemic, and you must look after each other. You must say hello to your friends and look after each other. And that includes the surgeons and people got to come out of the silos they normally work in and work together. You'll be doing things you don't normally do that you're uncomfortable with. And I think it's really important that we gather around and look after each other. So I would hope that this webinar will dispel some concerns and make people a bit more comfortable about airway management in COVID. I'm not sure my talk will, however. I think the other talk will. So this is a talk that I gave a couple of weeks ago. I would emphasize that there is a lot of resource in this hub that's been set up by the 4 organizations who are collaborating between intensive care and anesthesia in the UK. This was a blog that I wrote with Kareem El-Bogdadli, which is available, which goes through the numbers that I'll go through in a little bit more detail. But I'm mainly going to talk about numbers. So we can see if we go back a month or so that in February, between these 2 dates, Canada had 8 and then 9 cases, and the other countries had a few hundred cases. There were 3 epicenters. The epicenter was moving from China, probably to Italy and Iran, now 20 days ago. And the numbers of cases and the numbers of deaths were becoming really quite frightening. So these are the numbers that I will talk to explain the epidemiology of COVID-19 as we go through this. And again, just a couple of weeks ago, because that's when I wrote this talk, this was what the incremental graphs looked in terms of cases and deaths. And you can see they're at sort of 45 degrees as you go along those two along the axes. This was the number of cases we had. So up at the top, we have China with 80,000 cases, and South Korea starting to increase their numbers. The Diamond Princess at that time, that shipped moored off Japan, being an important contributor to the number of cases. And then just 10 days later, Italy increasing their numbers dramatically, again South Korea, and the Diamond Princess has disappeared off the map. But of course, all that is irrelevant. So a talk that was written 2 weeks ago is utterly irrelevant to what's happening now. You have to be up to date. So we're no longer moving along at 45 degrees on this angle. We're almost vertical on both these graphs. this table has become full of thousands and thousands of patients. The USA now exceeds China in the total number of cases, as does Italy. Spain and Germany probably will in the next day or two. So what does an exponential rise in cases look like, with a doubling time of perhaps 3 to 5 days in total outside China, but probably 2 to 3 days when things are at their worst? So this is what it looks like. 67 days to reach the first 100,000 cases, 11 days to reach the next 100,000, then 4 days, then 2 days. So that was 4 days ago, and now we're up to almost 700,000, and we'll be over 1 million probably in the next day or two. So these are horrific figures. They are frightening. Are those figures realistic? Doubling times of 2 to 3 days or 3 to 5 days? Well, that's what's happening just south of you in the USA, and we've got doubling times in this area here of about 2 days, 3 days here, and slightly longer there. But during the peak of the epidemic, the doubling time is roughly 2 to 3 days in terms of the people that turn up at the OR, in terms of the people who need advanced oxygen therapies or intensive care. This is you today, 5,500 patients. You take that forward without any modification to your rise with that doubling time, and you're looking at 1 million patients in a month. So that's the epidemic curve. It runs for about 20 weeks, if not controlled. So that's a 20-week surge. This is our NHS capacity and an expectation that we will be overwhelmed in terms of what we can provide for patients for a period of about 2 months without control of that curve. But if you lock down the country, and it does mean lockdown, you can control the curve. You can, after about 4 to 5 weeks, reduce not only transmission but also cases coming through, and control that epidemic surge. Reduce that wave from a tsunami to to a nasty, dangerous wave, but not a tsunami. And Wuhan 5 days ago had not had any cases for 5 days. So this is the curve. What it looks like, as I say, about a 20-week curve. And the aim is, with various different modalities of social control, to control what happens. Initially, the aim is to contain this virus, to reduce the actual numbers of transmissions, and therefore to reduce the size of the curve in total. But usually that fails after a couple of months, and then there's an attempt to delay. And all that does is to try to accept that the number of cases that will happen, but to spread those cases, so spread the area of curve over a longer period of time. There is some suggestion that by doing that, you may actually decrease the area under the curve as well. The big concern is that by suppressing that curve, by keeping people isolated, the virus simply goes into, as it were, into hiding. And then when you take off the social distancing and isolation procedures, that it re-emerges. But we hope that that won't happen. What's the mortality from this disease? Well, you could look at a lot of different studies, a lot of data from different places, and you come up with all these numbers. But you need to understand ascertainment, what the numerators are, and lead time bias to interpret any of these numbers. So let's look at this. This is the number of infections at the bottom, the numbers of identified cases, severe cases, and deaths. And what do they mean? So let's look at those numbers and come back to that pyramid. So the R0 is the number of patients that are infected by a single infected individual in an uncontrolled situation, so without any control being taken. If you can get R0 below 1, the epidemic will run out, and that's what's happened in China. But at 2.5 to 3, it's pretty potent. The ascertainment rate is the proportion of real cases that are identified. So there may be 8-fold more cases in society than we actually know about at any time. So when you hear there are 6,000 cases in Canada, there are probably 50,000 cases. And the attack rate is the proportion of the population which will finally get the illness. Estimated still to be somewhere between 30 and 60%, but the worst estimates are 80%. Of those, roughly 12 to 15% are hospitalized. Of the identified cases, 2% become critically ill, That's 1 in 6 are hospitalized, and it varies in China and Italy, for instance. And the overall mortality is roughly maybe 2 to 3 of those that are identified, but as we don't identify the majority of the cases, perhaps closer to 1%. This is effectively WHO's disease X. It's a disease which causes a broad spectrum of disease, from the most mild to fatal, and spread can happen early and throughout the disease, and this causes problems. So if we look at spread, so this is not flu. Flu has an R0 of about 1.3. So after 2 infective episodes, there will be about, the individual will have infected 2.2 patients. The R0s of other diseases are here. You'll see they're all below COVID-19. So this is the first 2 transmissions of COVID-19. And if we roll that forward after 10 passes, flu has caused 14 other infections, and the mortality rate is 0.003. But COVID, with these R0s, will lead to this number of cases after 10 passes, and because it's 100 times more fatal than flu, this number of deaths. This is a game changer. So here we have 100 cases that we know about. There may be 800 cases in the community. Of those 100 cases, somewhere between 10 and 15 will require hospitalization for a severe pneumonia, and depending on preparedness and the quality of care delivered, between 1 and 3 of those patients will likely die. This is perhaps the best paper on the epidemiology. It's a fabulous paper. Look at 72,000 cases in China. Look at the time from collecting data to publishing. And if anybody's in any doubt about whether the severity of illness described in those papers is what we would consider severe and critical, well, they're the same as we'd likely use. These are univariate risk factors. So there is a major inflection point in terms of age and case fatality rate, from the under 60s, where very few people die, to the over 60s, and particularly the over 80s, where many people die. There is a disproportionate number of males, and that's particularly seen in Europe, and healthcare workers, about 3%, I'll come back to that, are infected. These are, I think everybody will know now, risk factors, but again, they're univariate, and cardiovascular disease, respiratory disease, diabetes and hypertension, all important. Up to 50% of those patients who are critically ill die, and this is not just China, this is throughout the world. But also another thing I'll show is that the case fatality rate during this period, so as the epidemic went on, reduced dramatically, and that's not just lead time bias, so that some of these patients have survived so far but will die later. It's a genuine reduction as they've got control of the epidemic. This graph quite elegantly shows the rise in onset of symptoms for patients, and then the rise in the patients who are diagnosed. And it's typical that the patient will be ill for about 10 days before they require admission to hospital, become increasingly dyspneic, and then over a rather short period of time, these severe patients require admission to ITU. So a long period of mild symptoms and perhaps starting to struggle before they need to come to ITU. This is Li Wenliang, an ophthalmologist who tried to alert the world to this unexpected and unexplained pneumonia early on. Ophthalmologists obviously come in close contact with their patients face to face. He contracted the illness, unfortunately, aged less than 40, died of the illness. A very sad story. There is great concern about the risk to healthcare workers, and in the early study, this is 138 hospitalized patients from Wuhan. 41% of the infections were hospital acquired, and 29% occurred in healthcare workers. Now, these are obviously of great concern, but what I would emphasize is that this was early in the epidemic and probably before PPE was used. If we look at that large paper, this then looked at 45,000 of those 72,000 patients. About 4% of the patients who were identified were healthcare workers. I'm not sure what proportion of the overall population is a healthcare worker. And 15% were classified as severe or critical, which you'd think is about the same as other cohorts, roughly the same. But because the ascertainment of healthcare workers is likely to be higher than the general population, there is some concern that the infective load may be increased in healthcare workers, and therefore that the severity of illness is greater and mortality higher. This is similar data from Italy. This is their early reports from 13,000 patients, and they have an 8% healthcare worker infection rate. That's wrong. 8% of their patients were healthcare workers, and other reports I've seen that's high as 13%. So these are areas of concern. I'll finish with just one slide which gives some reassurance, and this is intubation associated with healthcare workers infection in Wuhan. There are 3 papers that look at this. This is a nice paper in anesthesiology which looked at about 2,500 intubations, reported I think no cases of associated healthcare worker infection. 200 intubations, a paper under review at the moment. Again, no healthcare associated infections in staff wearing PPE. And then going back to this study of the 138 hospitalized patients, those 5 deaths, all those 5 healthcare workers who died were thought to have acquired the illness outside the hospital and not related to their work in the hospital. So there is some reassurance. If you wear your PPE appropriately and you don't make mistakes and you are supported and do safe things during airway management, I think airway management in COVID disease can be safe. Thank you very much.
Thank you so much, Tim. It's Laura here for just giving us such a wonderful lay of the land. When all of us were at our team huddle before we went live, Tim said, you cannot talk about airway management without talking about PPE. And I couldn't agree with him more. And that's why we did PPE first and foremost in the webinar last week. And that's going to be coming out with a document shortly. So I want to go to this, and so I just want to present this very interesting paper, systematic review looking at SARS data that came out of 2003 in healthcare worker infections in Canada. And so essentially there's a lot of different things that are considered to be aerosol generating medical procedures, or AGMP. This was a new term for me. I didn't even know it 2 weeks ago, but there is high risk aerosol generating medical procedures, and the odds ratio for healthcare providers who do these different procedures compared to the chance of healthcare workers who do not do these procedures of acquiring SARS in 2003 can be seen here, and this is in a Canada setting. So positive pressure using bag valve mask ventilation had almost a 3 odds ratio. Endotracheal intubation just over 6. And the need to do cricothyrotomy is just over 4 of an odds ratio of, again, people doing cricothyrotomy compared to those healthcare workers who did not do cricothyrotomy. I have to use the caveat in the systematic review that many are case-controlled series or cohorts, small cohort studies, and these were combined. So we don't have a huge amount of information, unfortunately. And I'd also like to point out that the role of a supraglottic device back then in 2003 was much less than it is now. We didn't use it at all in resuscitation, for example. And so, you know, we just don't know what we're dealing with at present. Can I get the next slide, Dan? So airway management has fundamentally changed since 2003. It's now 17 years later, and even though we're looking at a huge difference in terms of the infections in the countries affected by SARS, we could almost call it, you know, SARS, you know, the second movie, from 28 countries to 200 countries. We also have better things to actually do airway management with. And I'm just going to review the things that we know now so well. Next slide, please. So we have extremely good evidence that a double-handed technique, if you must do positive pressure ventilation, with having your thenar eminence, your thumb on top, versus the classic CE grip, is just simply achieves a better seal with less positive pressure for similar tidal volumes. Tim, these are your pictures. Do you want to speak to this at all?
Sorry, just unmuting. I think just to reiterate what you're saying, I think some of the evidence is particularly in the obese patients for using what's that image on the right, the VE grip rather than the CE grip, but having the thinner eminences really almost touching each other, and having the thumbs pushing running along the mask longitudinally, and then using the other 4 fingers to bring up the jaw, to a chin lift and jaw thrust. That seems to be more effective in creating a seal and in clearing the airway. But perhaps what is missing in this picture is that there probably should be a Goodell and airway adjunct in there to maintain the airway at the same time. Back to you.
Extremely good point. And I have to say, as a female healthcare professional, I find that the VE grip allows my fingers, like it's not just my pinky that's bringing up that jaw, it's now all my fingers. So for small-handed people, this works so much better. If you have to do positive pressure ventilation, which we're going to actually talk about in detail very shortly. Next slide, please. So some good news stories here. Since SARS in 2003 to now 2020, our use of supraglottic devices has now been widespread, and now we have 2nd-generation devices which we can use with increased positive pressure ventilation, and we have a number of different types. If one supraglottic device doesn't fit well in your patient, the chances of a second one working are actually quite high, approximately 70%. We also have video laryngoscopy, which was not used that often in 2003. In fact, looking at the Toronto data, the first pass success rate for intubation in the ICUs there was 50%. And so the whole idea here with SARS and now with COVID disease is to actually optimize first pass success rate, and we know video laryngoscopy can be very helpful. One of the things with video laryngoscopy that you need to keep in mind is there's 2 kinds of blades. There's now the Macintosh classic, about 30-degree blade that you can use with video laryngoscopy, and the hyperangulated blade, which is the classic glide scope blade, first introduced in 2001 at 60 degrees. So know your equipment, know what you should use with what kind of patient in your own hands. And then finally, what we have progressed to is a simplification of cricothyrotomy. It is now a very straightforward procedure. There is not a lot of options, and being given a lot of options for something that you'll do once in your career is generally not a good idea. So now we have good data saying that a bougie-assisted cricothyrotomy using a scalpel and number 6 endotracheal tube is probably going to be your best bet should you get to that. So without further ado, let's go to some cases. So this is something that I've sent out on Twitter, and just as an aside, 2 years ago, I gave a talk at the Lucas conference in Montreal talking about how Twitter allows for a beehive mentality in terms of different people sharing information very quickly. I think what we're dealing with right now with COVID disease is exactly why we should all be on Twitter. And this is just a short mnemonic to keep a very macro view of the different sequence of details that we will go into. So the first thing that you do is you apply your PPV, you cover yourself and you check one another. Everything gets done outside the room before going in the room. The use of video laryngoscopy, 2 days ago, a very nice little article came out looking at distance from the face of the patient, and video laryngoscopy can be helpful to keep that distance. You need to intubate by protocol, which we'll get to. And really, doffing is probably the most hazardous procedure for you as a healthcare professional, so you need a spotter to do that with you. Again, the overlap with PPE. Next slide. Our first case, we're going to go through 4 cases in this presentation, but our first case we're going to go through fairly slowly. It's going to take up the majority of our time here. We'll still have time for questions, but I really wanted to deal with this one first and foremost, which is the COVID-19 patient in respiratory distress. Next slide, please. When should this patient be intubated? And I'd like to throw that out to the panel.
Maybe I'll take this question to begin with. George Mastoras here, emergency physician. So this is a patient that we're going to be dealing with a lot in our context. There's no clear consensus on this right now. I've seen anything from requiring an FiO2 greater than 50% to requiring an FiO2 greater than 80%. And then there's clinical indicators. You know, we often want to be looking for patients who are showing signs of respiratory compromise, fatiguing, failing to protect their airway, that sort of thing. But at the same time, there's emerging literature that suggests that some of these patients don't actually look as terrible as you'd think they would for the given saturation or PaO2. So there's definitely an element of clinical judgment involved, but certainly I'd be advocating for getting a patient who is deteriorating despite interventions and increased FiO2, that they be intubated in a controlled fashion prior to them crashing.
Excellent. Thank you so much, George, for chiming in there. Does anybody else have anything to add to that?
I can offer a point just from our local experience. What we have is 2 hospitals that are in close proximity that are a part of different health authorities. And so I think what's been a struggle is unifying the clinical trigger for consulting ICU and for early intubation. And I think this is a point to emphasize what George was saying, whereby it's the principle of early airway management before these patients decompensate that needs to be emphasized, and that likely the triggers at various sites are going to be different, but the guiding principle that you should decide the trigger for at your site is that you're going to manage these patients early before they decompensate.
Excellent point, Shannon Lockhart out of St. Paul's and BC Women's Hospital. Can we go to the next slide, please? So the purpose of this slide is to actually ask where should this patient be intubated, and there's been a lot of debate in terms of negative versus positive pressure rooms and the use of them, or the not use of them, and the need for a high turnover room and what that means. Can I call on Dr. Grocott to make some comments about this?
Thanks so much, Laura. And I think one of the issues here is that depending on your individual emergency department, the setup of your operating room complex or your intensive care unit, the whole issue of positive pressure versus negative pressure, quite frankly, maybe somewhat of a moot point in most institutions. The vast majority of the institutions simply will not have sufficient negative pressure rooms be able to manage these patients in. If you do have the availability of a negative pressure room, I think that the vast majority of the experts would agree that that's probably optimal for them. But I don't think that we're really going to be able to do this on the vast majority of our patients. I think the other issue, which maybe ties this particular slide with the previous one, as to where one should be intubating this patient in a situation where you have the ability to adequately prepare yourself and don your appropriate PPE. So, I think that's also something that's something you should think about. This shouldn't be happening in the hallway, hopefully, of the emergency department or in an unprepared operating room, where you don't have that ability to adequately prepare yourself. So there's a couple of issues there, both the positive and negative rooms, as well as the issues of proper preparation.
That's great. Thank you, Hilary. Can I get the next slide, please? So pre-oxygenation has been a big issue of discussion in ICU literature, in emerg and anesthesia as well. And so we wanted to dive into it a little bit because there is a lot of confusion, and I will forewarn you, spoiler alert, there is no clear answer for this. So can I get the next slide, please? So Tim, can you speak to pre-oxygenation versus the patient who requires increasing oxygen in terms of these different maneuvers?
Yes, I think so. What we're finding in the UK, which I think we're learning from Italian experience, is that initially, and I think I include when we were writing our airway guidance, which was only 2.5 weeks ago, the party line was high flow nasal oxygen dangerous, NIV and CPAP dangerous, other simple methods should be used. And I think we're moving away from that in terms of the modalities that patients will have on the wards, and therefore what the patients will be having. So while I completely agree that patients should not be being intubated, should be intubated before they deteriorate, and some of these patients arrive at hospital at the point of decompensation, we should not probably be throwing away the advanced airway techniques that we've relied on for some time. And I know in Italy, for every patient that's in intensive care, I've heard that 2 or even 3 patients will be on a ward receiving advanced airway or advanced oxygenation support, so NIV or NIV or CPAP or high flow nasal oxygen. In terms of pre-oxygenation, it seems, because of the aerosol generation, it seems unwise to start high flow nasal oxygen or to start CPAP at that time. However, if they're in place, it probably is not necessary to remove them. Appropriate PPE, of course, should be worn for what is going to be an aerosol generating procedure anyway. There is no evidence that I'm aware of that low flow oxygen, and by that I would say about 5 litres per minute, is aerosol generating, and therefore the benefits of oxygenation through the intubation procedure, apneic oxygenation, can be achieved by low flow oxygen in those patients who are particularly hypoxic. And I think I'll leave it there.
Does anybody else have anything to add? This is the meat of the matter here.
Yeah, echoing what Dr. Cook said, I think these are important interventions. If we look at the Italian experience, the Chinese experience, these are really important interventions to bridge probably a large number of patients and keep them out of the intensive care unit and off of ventilators altogether, considering what a scarce resource that's going to be. We do have to recognize that particularly the high flow nasal cannulas and the CPAP, BiPAP devices do generate aerosols, but the patients can and should be appropriately isolated. When we're talking about pre-oxygenating when the decision has been made to intubate, though, I think it's a bit of a different question, and certainly these devices are limited in supply in most centers. I know, for example, at my hospital at present, we have about 100 high ox masks at each of our 2 academic campuses. And so, you know, I wouldn't be using that for the purpose of pre-oxygenating somebody in whom intubation is required. And I'd rather favor a bag mask with a good seal and just sort of that passive respiration for 5 minutes.
Excellent comment, George. Thank you. Certainly, one thing that I do want to point out about high flow nasal prongs is they're not invented equally. And so dry oxygen off the wall without humidification probably actually makes more dry droplets that then can become airborne and aerosolized, versus humidified oxygen, we think probably creates bigger droplets than that drop closer to the patient. I think as we go along in this crisis, we're going to be finding out more and more. And as a bit of a droplet geek, I'm actually finding this to be fascinating, and I'm hoping that the use of these sort of things, modalities, will prevent us from needing to intubate all patients. Next slide, please. This is a slide that I just wanted to point out. This is courtesy of George Kovacs. Thank you. Shout out to you, George, in Halifax. So this actually shows how a BVM device can have the most important thing, which is the HEPA filter or the HEM filter between the mask, which is a tight seal on the patient's face, CO2, a waveform capnography, which is what they're using in the eMERGE there, and a BVM device with a PEEP valve. PEEP is also an issue. I think up to 5 is absolutely fine, but I'm curious to see what the panel thinks. Because the oxygen source comes after the filter, the flow of oxygen may be less less important at that stage in the oxygenation. And shout out to our friends in Australia. So the Safe Airway Society has just published their consensus statement, and I think this schematic at the bottom is lovely in terms of the sequence of different things that should be attached to either a ventilator or a BVM device. Does anybody have anything to add to this?
Laura, do you want to say something about the CO2 monitoring?
Yeah, you know, the CO2 monitoring, I think we're going to get to that in a couple of slides though, but we will emphasize it just down the road from this one. But thanks, Hilary, for the reminder. Can we go to the next slide, please? And so the principles of COVID management, I think we're all in agreement from every guideline, is full paralysis as quickly as possible using very large doses that we don't normally use. So, you know, anywhere between 1.2 to 1.5 milligrams per kilogram of rocuronium, and everything that you can do to optimize your first pass success means less aerosols being produced over time. And so these are the guiding principles to your airway management. Can I have people from the panel chime in about anything about that?
Totally agree.
I'll defer to Tim.
All right, so how do you make that happen? Well, we can go to the next slide. How you optimize your first pass success is by providing your healthcare professionals with PPE that protects them. If people are uncomfortable with their own PPE or personal protective equipment, first pass success, in my humble opinion, will go down. And this is a high-risk aerosol generating procedure of intubation, an N95 mask, face shield, goggles, head and neck cover. And neck cover is a bit controversial, but we're going to be going with that. An AAMI level 3 gown, double gloves so you can take off your contaminated gloves if other maneuvers need to be done, and washable footwear, which, as an aside, in Canada there's all kinds of knockoff Canadian Tire shoes that can be bought that are totally throw in the sink type of shoes, which I just bought. Can anybody speak to this? Shannon, can I call upon you?
Sure. I think what's important to understand is that given our shortage of PPE supply, which we're all very much aware of, that it's the principles once again, and I feel a bit like a broken record, but the principles of protecting ourselves with these high-risk aerosol generating medical procedures that the principles are emphasized on the left here. And what that means is you won't necessarily look like the person in this photo, but if you are abiding by the principles that you require airborne and contact precautions, and potentially identify that your neck is a high-risk area of contamination, this does not mean that your neck is a source of transmission. What it means is that you can self-inoculate yourself by touching your neck and then touching your mucous membranes. So if at your site you can't have neck protection, what you can do is potentially use something to wipe or clean your neck, or hit the showers, or use a face guard that hangs down longer. But we would just like to emphasize that it's the principles that are important, and that in fact the PPE permutations that you do choose will probably change over the course of this disease as supplies change and evolve. So again, just keeping in mind the principles of protecting yourself as the supply changes.
Thank you so much, Shannon. Can we get to the next slide, please? George, can I call upon you to talk about outside the room preparation?
Yeah, absolutely. So with respect to outside the room preparation, obviously the donning of the PPE is the first important step. I think many centers are moving this direction. We certainly have implemented, but using a spotter system or a buddy system whereby people are cross-checking each other's PPE, ensuring there's no breaches, for example, in the way that the mask is applied, the way that the gloves are covering the wrist and the cuff of the gown, and so on and so forth. There's also an opportunity there for a team pre-briefing and to run through whatever checklists or cognitive aids you have, talk about the plan for how the patient's airways can be managed, so that everyone goes in with a similar mental roadmap of how we're going to get from entry to secure tube. So that's an opportunity there that we should definitely take advantage of.
Yeah, and Laura, it's Hilary here. I just would chime in there as well that, you know, as one is talking about PPE and how to do it and where to do it, I will remind some of those listeners to look up our previous webinar from last week where we discussed some of these principles, and to look to the document which is just been submitted and under review right now, which should be published later this week as well.
And can I also make a plug for the importance of simulation in this? So we've really learned a lot about our physical and spatial constraints and how to best be able to don and doff in pairs, given your physical and spatial constraints. So I would highly recommend simming this and going through the motions, because it may not be possible in the way you think it's possible given your space.
Yeah, I couldn't agree more with that, Shannon. Part of this outside the room prep happens long before there's a patient requiring our care, in terms of getting our systems ready. And I think the slides ahead are going to speak to that a little bit, but making sure that the system is optimized and that the teams have been through it before and they're not figuring it out on the fly.
Dan, can we get the next slide, please? And George, this speaks to your prep.
Yeah, so this is our intubation tower that we now have set up at both of our hospitals, both in the Emerge and in the ICU, and hopefully soon on the in the ORs for anesthesia as well. What we've done is, in a collaborative fashion, we've developed these modular bins. So Airway Bin 1 is sort of the plan A with a view to pre-oxygenation and intubation with video laryngoscopy. Bin 2 is rescue, and it includes a bougie and a couple of supraglottic airways. We're using the eye gels where we are. And then Bin 3, which you can see at the bottom, is the equipment required for the bougie crate as a last resort. These bins are being mass produced. They're all identical. And the idea here is you can see that they're sealed with a tag. So we know that they're clean inside, and they've been checked in terms of the stocking. Those bins can be brought into the room, and typically what we've done is positioned a bin 1 in the room for intubation, a bin 2 in our anteroom or just outside the room, and then a bin 3 also just outside the room. They can be wiped off if they don't get opened with some sort of like Virox wipe, and then, like I said, everything that you need is in there, and it's very standardized. People know what to expect.
I think you've just spoken to the importance of standardization and predictability when it comes to airway management in these situations. Can I get the next slide, please? Tim, this is your setup that you have in the UK, and we don't really have a Mapleson C circuit, but I just want to highlight that again, it's the HEPA filter between the mask and the oxygen source, and between the mask and the CO2 capnography that's important. Can you speak to this, Tim?
Yeah, thanks, Laura. I absolutely agree about the filter perhaps being one of the most important aspects of this. But the general principle is that once you're in the room, people cannot join you quickly. So having as we call it, a kit dump, a visual representation of what you're going to take into the room is important. So you can make sure that you're not halfway through pre-oxygenation or halfway through or struggling with an intubation and realizing that you've not brought in an appropriate supraglottic airway, or you've not brought in the tube clamp for clamping the tube or the circuit before establishing ventilation.
Tim, can you speak more to the idea of having a clamp in the room? Because this is actually a new and highlighted particular thing with COVID.
Sure. So the aim is that the circuit through which the patient breathes, whether it be before anesthesia or well once intubated, the circuit that the patient breathes should remain uninterrupted, undisconnected as much as possible. By having the HEPA filter, or the HME as we'd call it in Europe, close to the patient, it means that the majority of the circuit should be virus-free. But if there are any points at which the circuit is going to become disconnected, and therefore the patient's airways could be potentially open to the room, then the aim should be that the tracheal tube is clamped and therefore obstructed, and that the ventilator is not just paused, but is actually stopped, so to whatever mechanism that means, to ensure there's no gas flow at that time. And by doing that, they should reduce avoidable aerosolization or spread of the virus into the room.
So can I open it up to the panel? Do you think that we should have a clamp on every bed of every patient who is intubated who has COVID-19 disease?
Laura, it's Hilary here, and I think this is a really good point, and something that, as we're ramping up to having these COVID patients present to our hospitals, that this is a really great opportunity to integrate this into your regular practice right now. So, for example, the last week, every time I'm doing a routine intubation on a patient, before I pull my laryngoscope out, I have that tube clamped before I hook up my anesthetic circuit. At the end of the case, if I'm transferring that patient to the intensive care unit, I just practice clamping that tube, hooking it up to the transport ventilator, and just getting to that habit that tube should always be, if you will, disconnected or blocked off from the atmosphere at all time points. And it's a great opportunity to start practicing that now, so it becomes part of your routine practice.
I totally agree. And we've been drilling that through about 20 hours of simulation in Ottawa with our respiratory therapists and our emerge teams. Our Airway bin 1, we actually stocked 2 clamps exactly for that purpose. The other thing that I'll mention, which isn't included in this kit dump, and I'll preface by saying I have no particular conflict of interest, is we're stocking what are called FLUSO valves, which are a closed 2-connection system that allows you to connect and disconnect the circuit or the self-inflating bag without having to cause a break and clamp. So that may be something that institutions may want to look into as well.
I think you bring up a good point, though, George, that we need to really look step by step at different things. And I think one of the things to avoid, I think clamps are important, or a valve that can do one way or the other, as long as you are properly trained. Buying new kit without actually really being oriented to it may open up one of holes of Swiss cheese in terms of trying new things where you shouldn't be trying new things. So adequate training, so important. And it also speaks to another thing, which is trying to MacGyver different things during a time of airway management, and therefore becoming a little bit less predictable to the rest of your team should probably be avoided as well. But that is another subject altogether. Can we get the next slide, please? Because I do want to talk about room management. Can I call upon one of our panelists to speak to this? Tim, I think you mentioned some very important things in our huddle prior to the webinar.
Okay, I'll just mention it briefly. This again comes from the UK COVID airway management consensus guidelines. So we have decided there should be 3 people in the room. That's 1 at the head. So the most, not necessarily experienced, but the person who is best skilled and to intubate. And so you're not expecting to be bailed out by anybody. So the intubator should be at the head of the bed, the person most likely to achieve first pass success. There is an assistant performing cricoid force if skilled to do it, and if not skilled to do it, I'd suggest it's not done, and looking after equipment. And then the 3rd person will undertake drugs and monitoring of the patient and timing the event. Now, it may be that at the peak of the epidemic, this may not be feasible and only 2 people may go into the room. However, before the surge and towards the end of the surge, it may be feasible to have 3 people in the room. And I suggest that if we change too many things from what is a normal and usually well-structured and well-performed technique, that we risk making things more dangerous for ourselves and the patients. And there are two people to look after during intubation, the COVID patient and the staff. And for instance, if we reduce this to two people and one person is required then to lean over the patient, give the drugs, turn backwards to look at the monitor, etc., while intubating, I think the chances for doing things that are non-ideal, for contaminating PPE or making mistakes have probably increased. So where 3 can do it, our recommendation is to use 3, but we fully accept that this may be reduced to 2 in some.
Thanks, Tim. I think that we have a couple of other panelists that want to mention something here. Shannon?
Thanks, Laura, and thanks, Tim. So I'd just like to mention that at our site, we've moved towards having a second anesthesiologist available, but not in the room, while we have the workforce capacity to do this. And the reason that we've moved towards this is that we recognize that in these cases that may be difficult airways, we don't have all the usual modalities for managing a difficult airway. And there are some modifications that have been mentioned that make subsequent management after a failed plan A more difficult. And so we at our site would like to address this by having a second anesthesiologist available outside the room who can then anticipate our needs and help us in this scenario where we don't have our usual modalities for difficult airway management available.
Great. Does anybody else have anything to add? I'm going to add one thing, which is it is possible to have too many people in the room. And during SARS, it looked like, and there was a signal, but not huge numbers, that that actually having more than 3 people in the room may be associated with increased contamination. And I hear what you're saying, Tim. If one person is, doing the airway while the other person has to do everything else, that may be associated as well. And I think through this, we're gonna end up finding out what the sweet spot really is in terms of number of people. Every person in there is more PPE being used, and yet on the other hand, the primary directive, which is protecting everybody while improving first pass success, needs to be respected as well. So next,
one more thing.
Sorry, go ahead.
One more thing I might add is that, whatever you choose in your institution, again, doing that in situ simulation is critical, and also re-emphasizing that whoever you choose to have in the room, to do that briefing beforehand, so all of those roles are clear to everybody.
Super. Next slide, Dan. Video laryngoscopy we've already discussed, but I just wanted to highlight here the use of a small screen versus a large screen. I actually would put a plug in for the use of a large screen and be that covered or whatever. Using a disposable handle versus a reusable, actually the virus that causes COVID-19 disease is actually a pretty wimpy virus, and actually is sensitive to just general hospital cleaning and reuse protocols. So you can use a reusable one. I think it actually allows everybody in the room to be on the same page, particularly your airway assistant, again, improving that first pass success rate. And I don't know about everybody else, but I'm getting a bit older now, and having just a 2-inch screen very close to the patient's face is going to seduce me into going closer to that in order to see. And I really don't want to do that in a point of stress, as I'm hearing those oxygen saturations nosedive before my first attempt is made. Anybody else have anything to add to that?
I'll just add with these video laryngoscope towers, a lot of them have baskets and supplemental equipment strapped onto the sides. And one of the things that we identified is that it ought to be stripped down for 2 reasons. One, makes for less waste of products that can't be properly wiped down and therefore need to be thrown out after the aerosol generating procedure. And 2, it will allow for a much quicker turnaround if you find yourself needing it in room after room. the more stripped down it is, the fewer baskets you have to clean in between all the wires and that sort of thing. So we've taken everything off of our tower except the screen itself.
Brilliant point, George. We're getting some questions about cricoid pressure, so I want to address that directly. We don't have a slide on that, but you know, RSI classically in anesthesia has been associated with a full stomach, and whether you believe in cricoid pressure or not, cricoid pressure used. That has since been questioned over the last couple of years in very large trials, but that was the problem with the trials. They were so large that they diluted perhaps the subset of patients that it's helpful in, those with a full stomach or upper small bowel obstruction. In this particular situation, though, we're dealing with something different. We want the patient not to cough in our face, and we want them not to cough in our face very, very quickly. So the putting on of cricoid pressure, I don't think is the point in this particular patient population. I think the point is to get them paralyzed extremely quickly and then to go from there. Can other people on the panel please speak to this?
This is Shannon, and I would definitely echo your statement and say that as we've talked about, avoiding the coughing is very important, and so early and high dose paralytics in the form of rocuronium. For most of us, some people are still using sucks, and then recognizing they will desat, and indeed that they are full stomach. However, our priority is to try and limit aerosolization. So avoiding cricoid, I would agree with.
Anybody else?
Yeah, from the emerge perspective, we've really moved away from cricoid pressure. It's also going to distort the anatomy, and really, we just want to get these patients intubated as swiftly as we can in a safe fashion. You know, it's funny talking to a group of anesthesiologists because you're all about to become emergency physicians alongside of us. And so I would also advocate that we could probably do without, but you know, individual preference is certainly permitted.
Can I come in on that? I'm going to say that I think if people don't know what they're doing with cricoid force, then simply don't do it. But done properly and by people who have been taught to do it, cricoid force will not distort the anatomy, and particularly when used with video laryngoscopy, may in fact improve intubation conditions, as has been shown in several papers. So I think it depends. It really depends on the group of people that are involved. If people are experienced and knowledgeable and skilled at it, then I don't think it's an unreasonable thing to do. And we tend to get very exercised about cricoid force. It's very simple. If it's causing a problem, take it off. And if you don't know what you're doing, don't do it. But I think perhaps, you know, we don't want to throw the baby out of the bathwater still.
You know, I think it all depends on you know, what your priority is in terms of, you know, whether you're worried about full stomach or not in a particular situation. But, you know, I think the priority of optimizing first pass success with first paralysis is a one-way street in these patients. You're not going to reverse with Sugamidex. Yeah, and I would personally discourage succinylcholine because I don't want a patient coughing on me as I struggle 7 minutes from now, potentially. George, this is your pre-intubation checklist to be done in the room. Can you speak to the importance of this?
Absolutely, and I'll acknowledge that this is the hard work of two of our senior residents, Nicholas Shuela and Jim Yang, who developed this in consultation with our colleagues in ICU, anesthesia, and trauma. We have started using this intubation checklist as a hard timeout before the induction agents are pushed. It's designed to be a call and response, and it's very similar to what I'm sure many of you are familiar with in the context of OR timeouts before things start. But it's basically targeted towards the nurse, respiratory therapist, and whoever's at the head of the bed. And it's just one final check to make sure that the plan is visualized, the equipment we require is ready, and then we can proceed. And then at the bottom, as you can see, there's a post-intubation call and response to make sure that we optimize that post-intubation care. Particularly in emerge, we start the sedation and analgesia thereafter, and so forth.
Thank you, George. Can I get the next slide, please?
Can I just add one thing, Laura?
Of course.
So if you can go back a slide, I think that these cognitive aids are super helpful. I think what we know is that if you arrive at an Airway and you're seeing this for the first time, it's not going to be useful for you in a time of high cognitive load where you're stressed and you have to do a task. And going through each of these things is going to add to your cognitive load rather than reduce it. So whatever checklist you use, you need to practice with and make sure that you're cognitively familiar with it so that it's helpful to you rather than a hindrance that adds to your cognitive load at a stressful time.
Thank you so much, Shen.
I absolutely agree with that. And I'll also just add that we have them in every single room laminated and hanging on the IV pole, because another barrier is, oh, geez, we got to do the checklist. Where is it? So just having it readily available.
Extremely good point. I've put this up here. Randy Wax, who's one of our collaborators who couldn't actually make it to our webcast today, you know, who does intensive care and disaster medicine, you know, says that, you know, you should just keep your induction meds really, really simple. And again, decreasing that cognitive load, intubating by protocol. And so I think it needs to be considered for your approach. Dr. Grocott, can you speak to your thoughts about cardiac arrest in these patients?
Sure, thanks, Laura. And firstly, this simplified protocol I think is very helpful for a couple of reasons. Firstly, before I get onto the hemodynamic issues, it takes some of the decision making away and reduces that cognitive load. Using that 100 kilo weight differential for your dosing, I think hugely successful. The final thing though at the end where it talks about phenylephrine,
I think we've lost you, Hilary.
I think is a really great opportunity to talk about the hemodynamic sequelae and that are being had. Oral pneumonias, they have very high pulmonary vascular resistance. They're very prone to right ventricular dysfunction, and the induction of anesthesia, doesn't matter what agent you're using as a hypnotic, ketamine or otherwise, despite the generally considered hemodynamic stability of ketamine, all of these patients are susceptible to hypotension, increases in their pulmonary vascular resistance, right ventricular failure, and cardiac arrest. And that's certainly been seen in the experience in China and Italy. So I think you really have to think about that very carefully before you begin. When I see similar patients such as these, in the intensive care unit that are needing intubation, I make it a regular part of my practice to speak to the intensive care unit nursing staff or my colleagues around me and make sure that I have in line and running a vasopressor such as norepinephrine and or an inotrope such as dobutamine or epinephrine, which can support that failing right ventricle in this time of significant hemodynamic compromise. So yes, get them paralyzed quickly, get them hypnotic before that, support their blood pressure, but don't forget about the hemodynamic sequelae that are going on here. And it's more than just a vasopressor. You have to think about the options for inotropic support at some point as well.
I can't echo that enough. I think that's such a good point, and we're starting to see that in the literature that patients can arrest on intubation. These patients are, their RVs are working extremely hard, which brings us to the next slide. So this slide is courtesy of Dr. George Kovacs in Halifax, and this is an arrest, and you can see chest compressions taking place as a reflection on the screen. There is still waveform, so all the usual principles of no trace, wrong place still apply here. Even if you see your endotracheal tube going through the cords, an immediate cardiac arrest after intubation, if there is no waveform present, it is in the wrong place. And Tim, can I call upon you to speak to this?
Yeah, I think, again, I simply agree with you. The assumption must be made, and there are patients who unfortunately do die because of esophageal intubation, and the assumption is made that when there is no capnography trace, that is due to cardiac arrest, and that is simply an incorrect interpretation. So If there is a flat trace, then it should be treated as an unexpected esophageal intubation, and that must be actively ruled out because there will be, even during cardiac arrest, a capnograph, a waveform capnograph trace which is attenuated, providing the tube's in the right place. There are other causes of a flat capnograph, but esophageal intubation is the most important one to exclude in the first instance.
And in cardiac arrest, you can see here the attenuated capnograph shows a CO2, end-tidal CO2 of 9. So it still is present. And again, thank you, George Kovacs, for providing that. Can we have the next slide, please? So there is a lot of algorithms out there about what to do first, second, and third. And again, I'm going to make a plug for your local resources to decide how you're going to deal with these patients. These patient saturations are going to drop like a stone. After you paralyze them, we do not want you to positive pressure bag them because it can cause aerosols. And yet you're then going to be intubating somebody who potentially has an oxygen saturation in the 80s, mid 80s, and going down, the 70s going down, and you need to be cognitively ready for that. So I'm going to make a plug again for simulation in this. On second attempt, you may or may not choose to either put in a supraglottic device or perform positive pressure ventilation using that overhand technique. And there is no good data on this, which is better. And whether you need to at all. I think at this point in time, it behooves you to perhaps consider if you fail a second time that probably your third time should be done by somebody else. And then the introduction of when to do a crike and if to do a crike in this patient, it being an aerosolized generating procedure as well. And I'm just actually going to, because this is, again, one of those primary things that's the meat of the matter, can I ask everybody on the panel to speak to this, starting with George?
Sure, I think you've covered it quite nicely, but in Emerge, we like to keep it simple. So for us, that two-hand thumbs down vice grip for pre-oxygenation, an optimized first attempt. If that doesn't go well, you can certainly look into what can be optimized for the second attempt, but recognizing that these patients may desaturate precipitously, either you can very judiciously and cautiously mask them back up, or that supraglottic device may provide a very important rescue. That isn't to say that a supraglottic device will contain all the aerosols. There's certainly issues with fit and getting it properly closed off around the glottis, but with judicious application of positive pressure, we can probably safely ventilate them that way and generate fewer aerosols than a mask that isn't seated well, or that we have to use big pressures to drive air into the patient. So I agree that would be sort of the first rescue for me. Try to optimize the technique, have it go again, or have a colleague try. And if it truly is a situation where you can't intubate, then and time is of the essence, then proceeding to that front of neck access.
Great. Tim?
Yeah, I think the point I'd make is that I'm not very keen on Nick Crime's drawing. That looks like a first generation supraglottic airway to me, and I think this is a situation for an airway device which is going to have a high airway seal, and therefore that in most circumstances means a second generation supraglottic airway. So that's likely to be, well, let's not go through the list, but a second generation supraglottic airway, which will have a high performing seal, and in these patients who are critically ill, your chances of rescuing the airway and of sealing the airway, both of which are important, are going to be increased by selecting the right device and using it in a skilled manner.
Excellent point. Hilary?
Yeah, I think Tim raises a good point, and I think it has to do, the point I want to raise is the familiarity with the equipment that you're using. And Tim, you make a really valid point about a second generation supraglottic airway. They're not available everywhere to everybody. And if you start using a new piece of equipment in this sort of situation, I think you are more likely to run into problems than not. So whatever you decide to use, make sure it's something that you use on a regular basis, so you have that familiarity. This is not the time to be trying something new. But I fully agree with you that when you look at the literature, the seal, the leak pressures, et cetera, better with the supraglottic air, with the second generation devices.
Shannon?
Yeah, not much to add. That's very thorough. I would echo what Hilary said in that it was mentioned that perhaps an intubating LMA would be the most, the best sort of rescue device, because then you could intubate through it. But at our center, a lot of people are not using these on a regular basis. So we've decided to go for the supraglottic airway that we're most familiar with.
Thank you very much. Next slide, please. This is where Airway meets personal protective equipment. So the doffing process is a very high-risk process. You've just intubated your patient. You are relieved, you're walking out of the room, and even if you've had greater than 2 hours of simulation, practice, and study about PPE, about donning and doffing, which has been, it showed in SARS that made a difference. That was the pivot point, was 2 hours of previous training, that mistakes can be made. You will not be an expert in self-contamination because you're not watching yourself. It's been suggested that perhaps if nobody's there to spot you, that you do it in a mirror. I couldn't disagree more. You really do need a person, and in a systematic review regarding how we protected ourselves with PPE using in the midst of highly infectious situations, and that was a Cochrane review done last year. The presence of a spotter reading aloud a checklist during the doffing process was the #1 way to decrease self-contamination and potential self-infection. I don't think that there's much else to say about that. Again, the PPE document will be out shortly. We're going to just do a couple of quick snapper cases highlighting particular things. Can I get the next slide, please? George, what do you do with somebody whose COVID status you don't know, who's in a trauma, and who comes into the hospital? How would you deal with that?
Well, I think at least for the Canadian audience here, we're at or reaching the point of community spread in every major city in the country. Certainly in Ottawa, we've implemented approaching all of these patients as if they are COVID positive, if we're unable to get any sort of screen that they aren't. So our team is donning, full airborne PPE, recognizing that there's a high possibility of aerosol generating procedures. This photograph is taken from a simulation that we ran in one of our larger negative pressure rooms. So we're trying to use the negative pressure room as much as possible. And we're recognizing that it's not just the intubation that's aerosol generating, but also potential surgical interventions at the bedside, chest tubes, thoracotomy, et cetera. And so just taking it sort of as cautiously as possible. If the patient's alert and talking and they can say like, nope, haven't been around anyone sick, I've been working from home for 2 weeks, I feel well. You could probably scale that down, but in a bit of an information vacuum like we work in, we're erring on the side of caution now.
All right, thank you. Next slide, please. Shannon, can you speak to the cardiac arrest patient whose COVID status is unknown, who arrests on the ward?
Absolutely. So I think that this answer is along a similar line to George's answer, whereby there's 2 main principles involved in this. And the first one would be, what are the appropriate precautions for the code team, given the community risk where you're at? So it sounds like in Ottawa, the community spread and transmission is high enough that all patients who come in are being treated as potential COVID positive. And in Vancouver, we've adopted a similar sort of strategy in that when we go to the ward and there's unknown history in these previously potentially asymptomatic patients, given the urgency of a code situation, we are donning airborne and contact PPE for those situations. So first responders prior to completing chest compressions will be in airborne and contact precautions. I think that there is a recognition that in a cardiac arrest situation, delaying chest compressions may lead to potentially worse prognosis and outcomes for these patients. However, again, preservation of hospital and healthcare workforce is quite important. And so because of our local community transmission, that is the policy that we've adopted. Again, the principle is going to be that you have to liaise with your local IPAC and talk about what your community transmission is, and then adapt these broader principles to what's going to suit your local site best. I think the other part of the Code Blue piece that we've worked through at our site is who's going to be managing that airway. And so for us, it's often a clinical associate overnight pre-COVID that would be managing these airways. And what we've done is rearrange our situation so that the most appropriate personnel, we're calling it, is managing the airway. So for us, that will be a staff anesthesiologist. So we've modified our setup so that 24 hours a day, there's a staff anesthesiologist available to attend Code Blues and COVID airways. And that's because our local community rates of transmission are high enough to warrant donning airborne and contact PPE for everyone performing chest compressions, and then intubating and extubating PPE for the 2 people performing airway management, with the idea that the code team will be able to stand back greater than 2 meters from the bed during the intubation. And so again, it's guiding principles that the appropriate precautions for the code team, given your local community risk, should be donned. And second, that the most appropriate personnel to manage the airway at your local site should be the one managing the airway, are the 2 main guiding principles that I'd like to emphasize for Code Blues.
Excellent, excellent points. Dan, can I get the next slide? Hilary, do you want to take on this discussion? I mean, this is what we're going to see in the OR, you know, a patient who's known to be COVID positive, but perhaps has milder disease with, you know, urgent surgery such as a perforated bowel. What would you recommend as an extubation strategy? And I'm putting you on the spot because we know such little about, so little about extubation versus intubation. But what are your thoughts on this?
Well, thanks, Laura. So this is a really interesting, case, because I think as we get more and more community spread, we're far more likely, firstly, to deal with a COVID patient, not in extremis in the emergency room or in the ICU, but just in our regular, perioperative and anesthetic practices. So I think extubation is a particularly, critical point, and we do have a somewhat of a knowledge gap in terms of how important this is in terms of the transmission of disease to healthcare workers, et cetera, et cetera. But there are some guiding principles here as well that we should take into account. And we know that extubation is likely a high-risk aerosol generating medical procedure. I think when you're deciding whether to extubate, firstly, you have to have that confidence that you are going to be successful, because I think you really want to avoid that risk of reintubation under slightly less ideal circumstances. So you want to make that decision with confidence that you're going to be able to keep that tube out. But I think you also have to extubate with the expectation that if you had to reintubate, that you have everything ready to do that in a safe manner. One of the frequent questions that I always get is, and particularly as we've published some recent work in the Canadian Journal of Anesthesia, about avoiding the coughing during extubation. And everybody has their own sort of nuanced practice in order to try to minimize this. There's been some recent work reiterating the potential benefit of an intravenous dose of lidocaine to try to prevent this, but certainly the principles are that you should try to avoid as much coughing as possible. It's interesting that one of the things that has been raised in some discussions is, well, if you want to avoid coughing, why don't you just do a deep extubation? And I think this is, again, probably one of the wrong times to be attempting a procedure that you are not facile with, that you don't do on a regular basis. So I would sort of caution against that. Others have suggested, well, extubate and deep and replace with a supraglottic airway. But once again, although in principle there may be some plausibility to doing that, but if you're not doing that on a regular basis, I think that I would caution against that. Now, once the patient is extubated, though, I think there's a number of things you do need to take into account, and I think getting a regular surgical mask onto that patient, over top of their oxygen source, I think is very, very important. And lastly, if you decide that the patient isn't a candidate to be extubated, to remember some of those basic principles about clamping the endotracheal tube when you're transferring them onto a transport ventilator, being sure that you have an HME or a HEPA filter, interposed between the endotracheal tube and the ventilator, I think are all important principles which one needs to take into account in these patients as it pertains to the issue of extubation.
Just brilliantly said, Hilary. So one last slide on my part, and then I'm going to hand over to Dan. When Shannon, Dr. Lockhart, was a resident and I was a younger staff person, we created the Airway app, and we've been following cricothyrotomy and other surgical airways in the last years, and published on that in anesthesia in 2018. And we're actually shifting gears, and I'm working with our programmers today, so I'm going to put a little plug in here. We're actually creating a questionnaire to find out more about the possibility of COVID transmission to healthcare professionals internationally. This is our website. It's called the Airway app. It's available on Google and on Apple. And our questionnaire regarding your experience with airway management in COVID is not up yet, but over the next couple of days it will be. I'll tweet about it when it's up, and I'm going to actually encourage everybody to collect your anonymous data. We do not ask you for identifying information about yourself or your patient. But we will actually be asking you, once you open up the questionnaire 2 weeks from now, from the time that you fill it out, the questionnaire, 2 weeks from now, it'll pop up a last question, which is, have you tested COVID positive? And we're hoping to actually start to put together some sort of more information and more education about the use of PPE and what PPE is appropriate, hopefully getting more numbers than we did with SARS, and be able to give clearer answers about both PPE and airway management. Thank you everyone for participating. Thank you very much to the other panelists. Tim, did you want to say anything as our guest from another?
If you don't mind, could I just open it up, because there are still a few questions, and I think in the interest of the Royal College and having some interaction, I'd like to just raise some questions and address it to the panel before people start to leave, if that's okay.
Oh, of course.
And I'm going to open this up to the whole panel. This came up a few times. It's about intubation teams. Could you all comment on intubation teams? Who's intubating in the in your hospitals?
I can answer that. We in the UK, as in a lot of places, in Italy, mobile emergency response intubation teams are being convened, so-called merit teams, and these are often anaesthetists, and the intensivists will look after the patient once intubated and transferred to the ICU. But a lot of the intubations are being done by dedicated teams of anaesthetists. There's potentially a lot to discuss there, but I'll leave it at that point for the time.
Shannon, do you want to make a comment?
Yeah, sure. So we are operating similarly, whereby we have a anesthesia-led intubation team to manage those cases that don't roll into the emerge so decompensated already that they need a crash airway. Our emerge team, and maybe George can speak to this as a concept in emergency medicine, has actually set up a tent outside of the emergency department, whereby they will be able to manage those patients that are so decompensated that they don't have time to call the anesthesia-led intubation team, and they'll resuscitate and manage the airway of those patients prior to them actually entering the hospital. For the ICU, we as anesthesiologists do have a team whereby we will be intubating those patients rather than the intensivists. And so what's just been emphasized across all three of those disciplines as we work collaboratively together is the need to stay in touch and inform each other about these patients as early as possible.
Yeah,
George?
I'll underscore your second point first, Shannon, which is the need for open lines of communication and collaborating with our peers across the hospital on approaches for this sort of thing. As it stands in Ottawa, we haven't established a dedicated airway team yet, but it's something that we're discussing and exploring right now. So I might have to defer answering that one.
So George, while you're talking, I've got another question for you. How do you decide when to intubate someone who's you suspect is COVID positive? What criteria would you use? Is it any different than non-COVID patients?
I don't think it should be that different from non-COVID patients, and I think the clinician's gestalt at the bedside sort of is paramount. The criteria that we're kind of looking at is increasing FiO2 requirements despite adequate intervention, and that would include things like high flow nasal cannula or BiPAP, CPAP. Any patient where you're expecting that they're not going to be able to protect their airway or signs of respiratory fatigue. Those would be my main criteria. We're just at the bottom of that accelerating curve. So again, we'll see what it looks like in a couple of weeks. But basically, you know, we don't want them in extremis when we make the decision.
Great, thanks. And Tim, a question for you. In terms of clamping the tube, this has come up quite a bit. What about if you've got a stylet or a bougie in? When do you clamp it? If you don't need a stylet or a bougie, do you clamp the tube before inserting it into the airway?
No, that would be madness in my view. I think you have to take those out in order to intubate the airway successfully. You have to take those out and then clamp the airway. I think there's a real danger, not just regarding this, but again around a lot of things. For instance, the plastic sheets, the Perspex boxes that people have been appearing on Twitter, of people starting to do things very abnormally from what they normally do. And I think the basic principle, these patients don't per se have difficult airways anatomically. They have physiologically and logistically difficult airways. And I think we still need to maintain our basic skills and our basic techniques. And those need to be modified to ensure the safety of everybody in the room, including the patient. But the basic principles that we've used efficiently and successfully for many years don't need to be abandoned.
Great. And Laura, I'm going to have a last question for you, and that's airway assessment and approach for the COVID positive patient. If you think they're already difficult to airway, would you change your approach to how you would manage the airway versus if you think it's an easy airway?
Oh, that is an excellent question. First of all, I wouldn't take off somebody's mask to assess their airway. If they have a mask on, I would just do it as a gestalt. And quite honestly, I think awake techniques are contraindicated. Anything that makes the patient cough and sputter at you as you're managing it. So shout out to Randy Wax for actually turning my head about this when I was trying to get all fancy dancy with non-aerosolized topicalization for these patients. He said the most important thing is our safety as healthcare professionals. So in those patients with an extremely difficult airway, I think sometimes a primary surgical airway would not be the end of the world. But again, you know, all the same principles, you know, profound paralysis is a one-way street in these patients. And even before doing that, I would have, if possible, a very serious conversation with that patient about what they want done.
Hilary, do you have any comment?
Yeah, Laura, let me ask you one scenario though, because I think, you know, we're all learning this on the fly without any question, and there are some unique circumstances that we're going to find ourselves in. And, you know, let me throw this question to you. If you had a semi-elective patient who's not an extremis, but they have a absolute contraindication to a surgical airway, the massive neck tumor, severe ankylosing spondylitis where you can't even lift their chin off their neck. I mean, you're really faced with a situation where you will have to do them awake. And I think that's potentially a very unique situation. Hopefully we don't come across that. But I think that I don't think all these things are always black and white. There's always going to be an exception where you will probably have to do an awake intubation in somebody. If I was in that situation, I would get the most experienced person to do it, the person that can topicalize, you know, in the slickest fashion and get this done. But I don't think we can always say no to the awake intubation. I sort of challenge you there a little bit. What do you think of that?
I think I love these discussions, and to be quite honest with you, you know, this is exactly what we were talking about on our Canadian Airway Focus Group meeting, talking about these situations. You know, I think that's really difficult, and you know, eventually some of us are going to be pushed to do awakes, maybe as we get more facile with these patients. But I think what I would also do is a bit of a pivot here and say, you know, the LMA that I throw in for an ankle fracture because I'm not very good at blocks, perhaps we need to relook at that and start to emphasize and highlight basic blocks for the non-regional physician as options for these patients and not interfering with their airway at all. And I look forward to having you know, an article such as, you know, 3 blocks for people that aren't regionalists come out in these times. You know, I think the other thing is, instead of trying to do an awake intubation, perhaps the use of an LMA or an intubating LMA may be useful. But, you know, we're out on a limb here, as you say. You know, it really does depend on what's best in your hands. But I think a second anesthesiologist is most definitely probably the most important thing to have in the room.
Great. So I'd like to take this opportunity, first of all, to thank all our speakers. It was an excellent webinar, and I really appreciate the time and effort you've all put into this. I'd also like to thank CAS members. Without members, this would not be possible, and I want to encourage all of the Canadian anesthesiologists who aren't members to please support more of this by becoming a member. And I'd also like to just mention that one of the reasons we have a lot of fear and uncertainty is that the literature, the evidence around this is really weak. And Laura presented their Airway app, and we also have our CARES incident reporting system. I don't think you want to think of these as mutually exclusive. We want as much information about these cases as we can possibly get, so that when this sort of event occurs again, and it will, we actually are better informed about how to manage these people, and we're better prepared. So I'd encourage you all to really, if you have these patients, start submitting incidents for all of them. Thank you, everybody, for attending. I'm sorry we went a bit late, and best of luck, and everybody stay safe.